It'll go quicker if you answer my questions. And guys, and if you have any questions, ask. If I've gotten anything wrong, please tell me. And also, if I start covering something that you guys haven't learned, let me know, and I'll just not cover it. Like this. Cool. You good? So, what we'll go through today, so we'll go through what the cardiac flow circuits are, so like the pulmonary system. You all right? So we'll go through the pulmonary system, the systemic circulation, that sort of thing, and then the physics concepts, the flow, resistance, compliance. We'll go through the electrical system, really basic, like just the pathway from the SA node to the Purkinje fibers. Guys, we'll go through the cardiac cycle. Have you guys been taught the Wiggers diagram or been shown the Wiggers diagram? Good, we'll go through that. Cardiac output, venous return later. Capillaries, the Starling forces, venous return. Blood pressure, I'll touch on it because I need to check with you guys how much you guys have covered the control of blood pressure. We'll do a bit of vascular endothelium as well. Do you guys have a lecture from Helena Parkinson about the endothelium? Yeah, okay, cool. What we won't go through is the head up tilt prac. Did you do there's a table and then you tilt? Okay, some people are nodding, some people are shaking. Okay, we did it. Okay, cool. So you guys did a physiology prac where someone's just on a table and flipping, and you were on bicycles was the other one. So I'm not going to go through that, but on the drive I've put up notes so you can just suss them out. I'm not going to go through ECGs, that's like another lecture and a half. But there's like 2 ECGs in here. Cool. So it's a lot. Cardiac phys is a lot, and it's nearly impossible to cover it all in 1 hour. Anything that I don't cover really well, read the relevant chapters in Guidance and Hall for it. It's a bit dense, but it covers everything really well. Also, if you want to like go down to a more succinct, compact resource, CV Physiology is good as well. And the other thing that I just wanted to mention, that this is your first system, and the rest of pre-clin will be taught in systems. So it's good to figure out a way of studying the systems. So I'd recommend splitting up notes into anatomy, physiology, pharmacology, that sort of thing. And focus on clinical pathologies rather than doing your notes lecture by lecture. Like, be a bit proactive about it. Anyway, hemodynamics and cardiovascular. So we've got 2 circuits. So this diagram shows, I can't get rid of that now. Go away. So we've got the pulmonary circulation going from the heart to the lungs, back to the heart. Then this diagram has split the systemic circulation into the upper circulation, which goes to the upper limbs and the brain. The lower circulation down here, which is for your lower limbs, as well as the portal vein circulation, which drains your, supplies and drains your abdominal organs. So the left heart is your systemic circuit, the right heart is the pulmonary circuit. So which is the more high pressure system? Hands up. Left system. So there's a mean pressure of about 95 millimeters of mercury in the left. If 84% of your blood is contained within the systemic circulation and 10% within the pulmonary circulation, where's the other 6%? In the heart, yeah, good. All right, so your options for these questions are arteries, arterioles, capillaries, venules, veins. So first one, which acts as a reservoir of blood? Veins, yeah, good. So the veins are really important when you consider venous return, and approximately 60% of your systemic blood volume is found in your veins, which is a primary functional control of blood pressure. Arterioles, good. They have strong muscular walls, and so they can close or dilate if needed. So they control resistance. In which portion are the walls of the vessel porous? Capillaries, good, easy. Which has the strongest muscular walls? Wonderful. And so there's just a slide showing the everything in a little bit more detail. All right, so physics concept. There's flow, resistance, and compliance, and we'll go through each one of them one by one. So flow, as a word, the definition is pretty straightforward. But if you look at this equation, you'll notice that flow is proportionate to the difference in pressure between the start of the vessel and the end of the vessel, and it's inversely proportional to resistance. So if you increase the difference in pressure, flow increases. If you increase your resistance, flow decreases. This equation only works if there's laminar flow through a vessel. So it's a very theoretical equation. So in blood vessels, if you have turbulent flow, this can stop off the equation. So who can tell me what can cause, like what's one cause of turbulent flow in a blood vessel? Pardon? Blockages, yep. So atherosclerotic plaques can cause turbulent flow. Anything else? So you can also have non-functional valves, so stenotic valves or just leaky valves, and stenosis in the vessel as well. So turbulent flow means that you need more energy required for flow. So if you're trying to put the same pressure, there'll be less flow overall. Resistance. So this is the impediment of blood flow in a vessel. So how difficult it is for blood to get from one point to another. So there's three determinants of resistance. There is viscosity, so how, I guess, thick your blood is. The length of the vessel, which is directly proportional. So the longer your vessel, the greater your resistance. And the radius of the vessel, which is inversely proportional. So out of these three, which is the biggest contributor to resistance? Radius, yes, good. So the radius of the vessel, the resistance is inversely proportional to the fourth power of the radius. So small changes in the radius result in big changes in resistance. So you get big changes in flow, right? And out of these, I think I want to ask a question later, but anyway, out of these three factors of resistance, radius is the important part. Length is important. So sometimes you might get an exam question that asks like, oh, you have like a 10 centimeter vessel. If it was 20 centimeters, what would the flow be, right? But viscosity is, like, don't worry about it. It's not that like clinically significant, but the radius is very, 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 very important. Okay, so compliance. This refers to the ability of a blood vessel to withstand changes to pressure, so how stretchy it is, essentially. So out of arteries and veins, which ones are more compliant? Veins, good. Why? More stretchy. Why are they more stretchy? There's less muscle, good. So there's less muscle, so they're less stiff, so they can withstand pressure changes a little bit. They're more stretchy. This is an equation. Okay, cool. So we've got a multiple choice question. The flow of a vessel is 100 mils per minute. The vessel is 1 centimeter in diameter. If the vessel were to double in diameter, what would happen to the resistance? Who wants to tell me the answer? C, good, excellent. So it decreases by 16-fold. This makes sense. So I wrote this out and thought it's kind of intuitive, but you can go through it anyway. So if your resistance is radius 1 over radius to the power 4, your initial radius is 1, so your initial resistance was 1. If it's double, it becomes 1/16, so decrease by 16-fold. Next question. A blood flow in a given vessel is 100 mils per minute. The radius is increased by a factor of 3. If the pressure doesn't change, what is the new flow? All right, who can give me the answer? I think I heard someone say E. E, good. So the answer is E. So radius altered the resistance by power of 4. So if your radius increases by a factor of 3, then the denominator of your resistance equation will be 81. Cute. And then I just did the maths, I guess. Okay. Electrical conduction of the heart. So we begin at so the electrical impulse begins at the sinoatrial nodes, the spontaneous sinoatrial node impulses, which travels to the atrial muscle, and then the impulse travels from the sinoatrial node, to the AB node via the internodal tracts that you see here. Yeah, that says Bachman's bundle up here. Don't worry about that. Next up, the electrical impulse goes to the bundle of His, where the impulse is slowed down, and that's really important. And then after that, the impulse gets split between the left bundle branch and then the right bundle branch. The left one gets the impulse first, even though the gap is like a millisecond. And then the left one splits into an anterior and posterior branch, and then the right bundle branch and then the left anterior branch become the Purkinje fibers that supply the rest of the ventricle and myocardium. An important thing that took me a while to understand is why there's a little negative deflection in the ECG. So I told you before that the left bundle branch gets depolarized before the right bundle branch. So if you imagine, say you're looking at lead 2 of the ECG, which goes from right shoulder down to your left foot. So it's sort of following the axis of your heart. So it recognizes positive deflections as impulses going towards the positive electrode. So for a moment, because the left one gets depolarized before the right one, it looks like the deflection is going the opposite way. Does that make sense? So that's why you get a negative deflection in the ECG. That makes sense? Does anyone want to go through that again? Yeah? So any positive deflection on an ECG is because the electrical impulse is traveling towards the positive electrode. That makes sense? So a negative deflection is because the electrical impulse is traveling away from the positive electrode. Because your left bundle branch, which is this one, gets depolarized before the right one, for a moment, it looks like the impulse is going this way. That makes sense? Yeah? So that's why you get a little negative deflection before the rest of the ventricles get depolarized, and then you get the rest of the QRS complex. All good? Cool. We've got lots of slides. All right. We have a question. So autonomic innervation will only modulate the heart rate since the heart rate has its own intrinsic rhythm. So what does parasympathetic innervation involve? I'm hearing people say A, which is maybe correct. All right, so the parasympathetic system only innervates the sinoatrial and the atrioventricular nodes. The sympathetic innervation does the entirety of the myocardium. Sympathetic increases the contraction of the heart because that's the only one that actually innervates the myocardium. Noradrenaline and circulatory adrenaline is sympathetic and it doesn't innervate the Purkinje fibers. So this table is important and it's also really nice and concise. So the sympathetic does the entirety of the heart, whereas the parasympathetic only does the nodes. Sympathetic relies on not only noradrenaline that's released by the nerves, but also circulating adrenaline from your adrenal glands, which act on beta adrenoceptors in the atria and the ventricles, whereas parasympathetic releases acetylcholine that acts on muscarinic receptors. So because the sympathetic innervates both the nodes and the myocardium, you can increase the heart rate and increase the force of contraction. Whereas parasympathetic only innervates the nodes, so you can only decrease the heart rate. You can't do anything about the contraction. Any questions about that? No? Good. All right. Someone is running. Because they're running, their heart rate increases. Why does this happen? All right, this one's an easy one. Who's got an answer for me? D? Yeah, it's D. This is what we just went through. So if you're running, then you're increasing sympathetic activity, and running sympathetic activity also increases circulating adrenaline. Cool. So sinus tachycardia shows up like this on an ECG. Can anyone tell me really, really roughly what the heart rate here is? 150. Yeah, good. So 300 divided by the big squares, for rough estimation. All right. Which has the fastest intrinsic rate? Sinoatrial, AV, or Purkinje fibers? Which one has the fastest rate? Sinoatrial node. So sinoatrial node is about 60 to 100, whereas AV node is about 40 to 60. So if the Purkinje fibers are the slowest, why is the heart's normal pace still 60 to 100? Yeah, so follows the fastest. So what happens is that the fastest intrinsic pacemaker just suppresses the activity of all the other areas that can have their own pacemaking abilities. What between cells facilitates coordinated contractions? Gap junctions, good, and intercalated discs. All right, so there is an AV delay. Why is there an AV delay? A lot of mumbling. So you have an AV delay to allow for complete emptying of the blood from the atria to the ventricles. So you have coordinated filling of the ventricles. Does anyone want to tell me how, like how there is an AV delay? Like what about the AV node creates the delay? There's less gap junction. Good, excellent. All right. Oh. So this is kind of important, kind of not, mostly important. So there's two different kinds of depolarization between cardiomyocytes, so like the ventricular cells, as well as pacemaker cells, and each of them occur in phases. Now, I don't suggest that you memorize this, but I suggest that you understand it, if that makes sense. So you just need to know that there's sodium, calcium, and potassium, and this table just has what channels they are. I'll go through each of them in the next couple of slides. Sodium, calcium usually come in, potassium goes out. So we begin with cardiomyocyte potentiation. There's 5 phases, but we start with phase 4 because why not? So phase 4, you have a flat resting membrane potential at approximately negative 90 millivolts. Next up, at phase 0, you've got rapid depolarization because of rapid voltage-gated sodium channels opening. So you've got heaps of sodium coming in. And then what happens at the top is that you've got transient potassium channels opening. So you get potassium leaving. You got potassium leaving. So you get partial repolarization. So it goes down just a little bit. And then you've got, in phase 2, you've got latent calcium channels opening. So you've got potassium leaving, but calcium coming in. So that results in a sort of a plateau phase at around 0 millivolts. And then phase 3, potassium channels open. So you got rapid repolarization, and then you're back to phase 4 at resting membrane potential. So this is a really good diagram of that. It is missing, however, it's missing one of the, it's missing the transient potassium channels in phase 1 that allows for some of the potassium to leave the cell. And there's intracellulars here, extracellulars here, and it just lines up with each phase of the cardiomyocyte potentiation. Make sense? Yeah. So this is different from pacemaker potentiation. So we have a thing called a funny current. The pacemaker cells never have a true resting membrane potential. They have instead a funny current, which is facilitated by the funny sodium channels. So these channels are open in phase 4. So they allow for slow depolarization. And eventually, still in phase 4, you get your transient calcium channels opening, and they allow more calcium channels to calcium ions to enter the cell. So it just helps the cell reach the threshold levels that for the other calcium channels to open. So the L type, the latent calcium channels open, and so the cell quickly reaches depolarization at about positive 10 millivolts, and then the sodium and the transient ones close. Phase 3 and 4 is when the potassium channels open, so you get an outflow of potassium and you get repolarization. All of the other channels are closed, and then at sort of negative 60, the potassium channels close, and then the funny sodium channels open again, so you get the funny current restarting. And this is a nice diagram. It's very pretty. It's from Amboss. I didn't reference anything. Yeah. Anyone have any questions on that? Also, I'll put up the slides. I didn't put up the slides because there's questions and I didn't want you to cheat. Okay, do pacemaker cells have a resting membrane potential? No, because they have a funny current. They have no true plateau phase. Which can have a membrane potential of negative 90, cardiomyocyte or pacemaker cells? Cardiomyocytes, because pacemakers only ever go down to about negative 60 millivolts. Yeah, that's enough of that. All right, the other thing to note is why is cardiomyocyte muscle physiology different to skeletal muscle activation? There's two things. So you've got a longer absolute refractory period in cardiac cells. That way there's coordination in contraction that allows for the chambers to be filled. The other thing is calcium-induced calcium release. You don't have that in skeletal muscle. So you need external calcium for cardiac muscle activation, which is why we have like calcium channel blockers, because they work in the heart. So if there's more calcium, there's going to be stronger contractility. So in summary, so cardiomyocytes, when their action potential is generated, extracellular calcium enters the channel, and that calcium binds to the receptors in the sarcoplasmic reticulum, and that causes calcium to be released by internal stores. Whereas in skeletal muscle, it's just the action potential that does all that. So the action potential is propagated into the T tubules and the sarcoplasmic reticulum, and that causes calcium release from internal stores. You don't need external calcium for skeletal muscle activation. That's possibly all you need to know about that. Cool. Man presents to ED complaining of dizziness and chest pain. An ECG shows an atrial contraction rate of 90 beats per minute, but also shows a 3rd degree atrioventricular block, which is a complete blockage of the AV node. What could his peripheral pulse rate be? All right, who's got an answer for me? B? Yeah, good. So even though atria are going along at 90 beats per minute, that signal is not getting to the ventricles. So the ventricles are relying on the Purkinje fibers to contract. And the Purkinje fibers can only go to about 20, roughly 20 to 40 beats per minute. Out of interest, this is what a ECG for a 3rd degree AV block looks like. There's coordination between the P waves, so the atrial contraction. So if you look at the distance between each P wave, you'll notice it's same roughly. And if you look at the QRS complexes, it'll also be the same. But there's no coordination at all between the atria and the ventricles, which makes sense because those signals are blocked. Cool. I think that's the last ECG. Shmuley has had a heart transplant, which is true. Her resting heart rate is, I can read the answers. All right, who's got an answer? Anyone? Who thinks A? Who thinks B? Who thinks C? Who thinks D? So it is C. So the sinoatrial node, the normal, if you take away, if you give someone a heart transplant, you take away autonomic innervation, right? Because you're just sticking in a new heart. At rest, when it's not affected by autonomic innervation, the heart rate in beats per minute is actually approximately 100 beats per minute. At rest, we have a heart rate of about 60 beats per minute, which means that in people with native hearts, we have an overall parasympathetic tone, right? So if you give someone a heart transplant, they can't modulate their heart rate with sympathetic or parasympathetic innervation, but you've still got circulating adrenaline. So you can increase your heart rate, but it will just come back down to 100 once you're done. So that's just an explanation of that. Does that make sense? Yeah, cool. Cardiac cycle. So you guys said that you went through Wiggers diagram, didn't you? Yeah. How in depth did you do this? Huh? Pretty in depth? Okay. I don't recall doing this, but we did it. Anyway, so the Wiggers diagram is it's a good way of showing different measurements of cardiac physiology on one diagram. Guys, it's a good way of showing different cardiac physiology concepts on one diagram. So you've got ECG down here. The ones that are important to see is ECG, ventricular pressure, and the phonogram that just shows you where the sounds are. Now, there's all this stuff. I know, I hate this too. What I suggest is to learn this by sections. It's pretty intuitive if you sit down and you try to understand the Wiggers diagram and you spend a bit of time on it, it's intuitive. It makes sense, but there's not always a lot of time to do that. So what I like to do in the way that I learned it is through categorizing different things. So for example, where the isovolumetric changes are. So phase 2 and phase 4. So if we go back to the Wiggers diagram, that's isovolumetric contraction is here, and isovolumetric relaxation is here, and it's between the ejection. So the isovolumetric contraction is when there's no volume change in the ventricles. So this happens when the ventricles have just been filled and they're just beginning to contract. So phase 2 coincides with the QRS complex on the ECG. So the ventricles are just starting to contract, but the pressure isn't great enough to open the pulmonary and the aortic valves just yet, but the atrioventricular valves are shut. So it's kind of like you're squeezing a closed toothpaste tube. The pressure rises rapidly, but the volume doesn't change, and it's QRS complex. The other isovolumetric change is isovolumetric ventricular relaxation. So you've just ejected all of your blood into the aorta, and the aortic and pulmonary valves have just shut. Now the ventricles start to relax, and this is a silent phase on the ECG after the T wave, between the T wave and the P wave. So the ventricles are relaxing, and the pressure inside is dropping, but there's no volume change. Eventually, the pressure change will be the pressure change will be lower than the pressure in the atria. So then the atrioventricular valves will open and the ventricles will start filling again, and that's going into phase 1A. Does that kind of make sense? So that's that. The heart sounds coincide with the isovolumetric phases of the cardiac cycle. And the other bit is where the silent ECG is. So it makes sense. It's going from phase 4 to phase 1A. So phase 4, we talked about the ventricles are relaxing. And then phase 1A is when the atrioventricular valves open and the blood from the atria start falling into the ventricles. So this is just before the atria actually contract and force all the blood in. So it's just before the P wave. Yeah, cool. Once again. So just learn it yourself. There have been past exam questions just about like what ECG changes coincide with the isovolumetric changes, etc. So it's good to know what the categories are, but learn it in sections rather than trying to learn the entire thing. Cool. This is like the 1 out of 2 memes I have in here. All right, cardiac output. So what are the 2 determining factors of cardiac output? Stroke, heart rate, and stroke volume. Good. So stroke volume is liters per contraction, and heart rate is contractions per minute. Therefore, what are the units for cardiac output? Liters per minute. Yeah. And then how do we calculate stroke volume? End diastolic volume minus end systolic volume. So it's how much the ventricle has been filled versus how much has been ejected with each contraction. So this, I wrote this, and I think it might actually be kind of wrong, but end diastolic volume, preload, and venous return are kind of all the same thing. If you think about it, it's just the blood that's left in the ventricles when they fill. Kind of mean the same thing, but just, yeah. Which would decrease your cardiac output? C. Good. Oh. So if you decrease venous return, you get decreased cardiac output because cardiac output and venous return are equal. If you increase end systolic, this would increase stroke volume, so that would actually increase cardiac output. If you decrease parasympathetic, then you get an increased heart rate, and if you get more adrenaline, there's increased heart rate and contractility. Well, that's halfway there. We've got a lot to go through. So cardiac output, you can alter it by either altering stroke volume or heart rate. Stroke volume, you can alter by changing the muscle length, which you can change by changing the end diastolic volume, which is the Starling mechanism, which I'll go through later. You can also alter stroke volume by changing like the amount of calcium available to cardiomyocytes. So you can change the amount of extracellular calcium, or you can increase sympathetic stimulation because that allows for increased extracellular calcium entry, which both result in increased or change contractility. But also you can alter your autonomic output into the SA node, which can increase or decrease heart rate. Cool. Sorry, this slide looks like giving me epilepsy. So the Starling mechanism is genuinely just a fancy way to prove that cardiac output equals venous return. So it's the compensation mechanism of the heart that adjusts your stroke volume according to your venous return in order to maintain your cardiac output. So what happens is if you have increased venous return, there's going to be increased pressure in your ventricles. If you have increased pressure in your ventricles, that it results in increased stretch of your muscle fibers. That results in greater overlap of your thick and thin fibers. So you have a stronger contraction force at the end, which increases your stroke volume and it increases your cardiac output. All makes sense? Pulmonary congestion does the same thing. There's just the fact that there's increased pulmonary blood volume. So that means there's increased pulmonary vein pressure, increased left ventricle volume and pressure, and then you've got increased venous return. They're just the same thing. That's actually all you need to know for that. There's like all these graphs and shit, but you don't need to know that. Circulation. Is the flow through arteries intermittent or continuous? Hands up for intermittent. Hands up for continuous. Yeah, good. I asked a 50 of the answer to this and she said she got it wrong, so well done. So the flow through arteries is continuous despite intermittent input from the heart. What feature about arteries allows the flows to be continuous? Yeah, elasticity. That's what you're going for, yeah? Yeah. So the elasticity of your big arteries allows for continuous flow. This is important because you've got your mean arterial pressure. So your mean arterial pressure is your average pressure over one cardiac cycle. And in arteries, in big arteries especially, in systole, 2/3 of the blood volume are responsible for keeping your arteries open, whereas 1/3 actually participates in flow. In diastole, the rest of the 2/3 now participate. So this actually explains the equation for mean arterial pressure because it uses the blood that's participating in flow. So you've got 1/3 of systolic and 2/3 of diastolic. Make sense? The other important equation is pulse pressure, which is just systolic minus diastolic. It's, yeah. Cool. So systolic pressure is 120, diastolic pressure is 90. What's the mean arterial pressure? All right, who's got an answer? Hey, good. So it's 1/3 of 120 and 2/3 of 90, which is 100. All right, a patient comes in with incredibly non-specific symptoms. You do every investigation you can with your limited knowledge. Their ECG is normal, their temp is 38, their rest rate is 12, their heart rate is 84, their blood pressure is 130/85. The cardio registrar, for some reason, wants to know the pulse pressure. You correctly answer. B, yes. Pulse pressure just is just systolic minus diastolic. Easy ones. All right. This is the second mean and the last one. All right. So arterioles, they control resistance and thus they control blood pressure. So we talked about how arteries are mostly conduits for blood, so they just carry blood from point A to point B, whereas arterioles are the ones that actually control resistance. So there's a bunch of stuff that arterioles can do. One is control hyperemia. So hyperemia just means more blood. So you can have active hyperemia and reactive hyperemia, and it makes sense because active hyperemia is when you're actively dilating the arterioles, whereas reactive is that they're just dilating because you'd squash them beforehand. So active hyperemia occurs when you're exercising, and because your skeletal muscles are undergoing increased metabolism, there's chemical changes. So there's decreased oxygen in the area, increased CO2, increased hydrogen, increased ADP because you've used lots of ATP, and all of that result in arterial dilation. Reactive hyperemia is something that occurs after transient ischemia. So there's the exact same chemical changes that area of the body hasn't received enough oxygen, but it's because you've squashed the arteriole and you're just allowing it to open up again. If you look at a graph, active hyperemia is a more gradual process, whereas reactive hyperemia sort of shoots up. The other thing is physical control. So arterioles control your myogenic response to stretch. So if you have increased stretch in your blood vessel, that results in constriction. And if you have decreased stretch, it results in vasodilation. And that maintains constant flow, even if you have pressure changes upstream. The other thing that's pretty straightforward is temperature. If it's hot, vasodilates. If it's cold, vasoconstrict. Ease. Okay. Capillaries. So the main function of capillaries is to allow for diffusion of the water and solids. And there's 4 Starling forces that Chris Wright should have gone through with you. So the internal and external hydrostatic and the internal and external oncotic. At the start of the capillary, you've got your pressures overall will favor filtration, will favor pushing out fluid. As you go along your capillary, you'll get more and more proteins left in your capillary. So your internal oncotic pressure will increase. So that means by the end of your capillary, there's the forces will favor absorption of fluid, which is why you have net filtration at the beginning of your capillary and net absorption at the end. Yes, so internal hydrostatic is the pressure that your fluid puts against the walls of the capillary and pushes out. External hydrostatic, the fluid in the interstitium that pushes into the capillary. Internal oncotic is caused by the proteins present within the capillary that pulls water in, whereas external oncotic is the proteins outside the capillary that pulls water out. So we've got some questions. Your options are like the internal, external, hydrostatic, oncotic. I forgot to write that. Anyway, the pressure exerted by the fluid in the institution, this aims to push fluid into the capillary. External hydrostatic, good. The pressure exerted by the proteins in the interstitium. External oncotic. The pressure exerted by the fluid within the capillary due to the pumping of the heart that pushes out fluid. Internal hydrostatic. And then the last one is the pressure exerted by the proteins in the blood. So this is your internal oncotic. All right, so in a normal human being, in the capillaries of a normal human being, as in like someone who doesn't have pathology, not like an alien, is there net filtration or net absorption? Net filtration. So Chris Wright's lecture should have gone through like how you're pushing out more fluid than the capillaries absorb by the end, right? That's, I always get annoyed when lectures are like shush, but now I like totally understand. So there's net filtration in capillaries. So why don't we have edema all the time? Because of the lymphatics. The lymphatics, is it a one-way or a circulatory system? It's a one-way system. So it's a closed one-way system, which means that the entry into the lymphatic system is like a one-way flap. So you don't have stuff leaking out of the end. Do lymph vessels have valves? Yes, good. And where do they all eventually drain into? Yeah, vena cava, subclavian vessels, the subclavian veins, which then drains into the superior vena cava. All right, so you've got a patient coming in with bilateral basilar crackles, which means you can hear crackles at the base of their lungs. Why has this occurred? All right, who's got an answer for me? B. B is the answer. All right, so you get pulmonary edema, guys. So you get pulmonary edema because your left heart fails to pump properly, which results in fluid being backed up in the pulmonary system. So you get increased hydrostatic pressure in the lungs. So then you get pulmonary edema, which manifests as crackles in your lungs, and crackles at the base of your lungs. Peripheral edema, conversely, is what you get when you have failure of your right heart to pump properly. So you get fluid backed up in your peripheral system. So there's increased hydrostatic pressure in your peripheral system. So you get peripheral edema. So that ends up with pitting edema in the calves, or if you're like a bedbound patient, you get sacral edema, which is why you check for those in your cardio CSSE, OSCE, whatever. Veins. So there's another equation. This equation is quite simple to understand. So pressure means systemic, the PMS. You can consider it just to be the peripheral venous pressure, the pressure in your venous system. That's what it is. The PMS is your pressure in your venous system. PRA is your pressure in your right atrium. Remember your flow diagram. The flow occurs because of a pressure difference. So that's why there's a pressure difference here. So in the right atrium, what do we consider the pressure to be? 0. So your right atrium pressure normally in someone who doesn't have pathology is 0. So the pressure difference to generate flow is your pressure in your veins minus hopefully 0. So RVR is your resistance to venous return. Is this important? Yes or no? It's not important. So I remember last year I had a long argument with Chris Wright about this. So it's not important in veins because the venous system in general is a very low resistance system. So your biggest changes come from your pressure changes, not from resistance, because you can't change resistance to like resistance to venous return. But you can alter PMS very easily. All right. So we can do 4 things to increase venous return. You can increase sympathetic nervous activation. So what that does is it contracts and stiffens the walls of veins. So it doesn't do anything about the radius, it just stiffens the walls of the veins. So because you have stiff veins, that increases your peripheral venous pressure. So remember in our equation here, it'll increase this pressure, so there'll be a greater pressure difference. So that'll increase your flow. You also have muscular pumps in your in the skeletal muscle of your legs. So when you run and walk, it squeezes the veins in your legs. And because you're squeezing the veins, you're increasing peripheral venous pressure. So you increase venous return again. Same thing with your respiratory pump. So you have veins, like a significant venous system in your abdomen. So every time you breathe in, you squeeze those veins as well. For the muscular pumps and the respiratory pump to work, you actually need functioning one-way valves. So if you've got a pathology in your valves, then that's not going to work, and that's how you end up with varicose veins in your legs. Also, if you fluid resuscitate someone, you increase the volume in their vein, which puts increased pressure on the walls. So that increases your peripheral venous pressure, your PMS, which then increases your venous return. Does that all make sense? Yeah. Cool. So the venous return to the heart of a healthy individual would be expected to increase by all of this except. Who's got an answer for me? This is B. So increase in right atrial pressure. Remember your equation, it's PMS, peripheral venous pressure, minus your right atrial pressure. So if you increase your right atrial pressure, you'll have less of a pressure difference. You have less flow, less venous return. Increasing contractile activity is just muscular pumps. If you increase sympathetic stimulation, that creates stiff walls. So that increases your pressure in your veins, which increases your venous return. And then you've got respiratory pump, and then sympathetic would increase your cardiac output, which would increase your venous return. This is really, really important. So in arterioles, or arteries, the arterial system, the biggest change in flow comes from changing the radius of the vessel because it's to the power of 4. In veins, the biggest change in flow comes from changes in venous pressure, which comes from muscular stiffening. Contracting does 2 different things. So the sympathetic drive in arterioles, it will contract the muscles and will actually decrease the radius. This increases resistance and results in reduced flow, right? In veins, the same sympathetic drive will contract the muscles and stiffen the walls of the veins. So you end up with an increased venous pressure, and because there's a greater pressure difference between the veins and the right atrium, you get increased flow. Does that make sense? Does anyone want to go through that again, or no? That all makes sense? Easy. Blood pressure control. Okay, so I'm gonna show like 4 things, 3 things, 1, 2, 3 things, and just tell me whether it's part of the acute control system or the long-term control system. So baroreceptors, acute, good. The RAS system, long-term, and then the sodium blood pressure set point. Did you guys actually cover the sodium blood pressure set point? Cool. I'm not really going to cover it because it's not relevant. We didn't do it either. Good, we didn't do it. It's actually, shh. We don't study things you haven't learned. Where would you find your baroreceptors? There's 2 places. Yep. You find them in your carotid sinus, so the bifurcation of your common carotid into your external and internal, as well as in your aortic arch. And there's a diagram later that will show exactly where they are. Cool. So acute control of blood pressure involves baroreceptors. So this mechanism is seconds to minutes. So if you have high blood pressure all of a sudden, you've got increased vessel stretch in your carotids and in your aorta. So there's an increased firing of your baroreceptors, which sends signals to your brainstem. So you end up with increased parasympathetic tone, which result in vasodilation and decreased heart rate and contraction, which result in lowered blood pressure. The opposite is your baroreceptor reflex, which occurs when you have sudden hypertension. So people like who stand up and then they pass out, or people who have mild blood loss, this is what happens in as a reflex. So there's reduced firing of your baroreceptors, which increases your sympathetic response, which increases your total peripheral resistance, and then that increases your blood pressure. So here's the nice photo. So that's where the carotid sinus ones are, and that's where the aortic baroreceptors are. This picture is also from Ambos, I should reference. So long-term control is done by the RAS system. Forget about the sodium blood pressure thing. Hey, did you guys cover the RAS system? So my advice, you will revisit the RAS system next year when you do renal. Don't feel like you need to understand it completely, okay? A lot of these concepts will come back when you start learning about the kidney. So yeah, I don't know if you learned about it. So the RAS system, it's just steps. So if your blood pressure is low, your liver releases angiotensinogen. So a quick thing to remember is whenever you have a gen at the end of a word, it's a protein that needs to be activated by something else. So angiotensinogen is released by the liver. Renin is released by the kidney, which turns angiotensin into angiotensin 1. And then angiotensin 1 is converted to angiotensin 2 by the ACE enzyme, and the ACE enzyme is produced by capillaries in the lung. So angiotensin 2 causes aldosterone to be released by your adrenal glands. And so that results in increased sodium retention. So if you keep your sodium, you also keep your water. If you keep your water, you'll raise your blood pressure. So the RAS system over time would raise your blood pressure. Don't worry about that. Vascular endothelium, we're nearly done. So this was, yeah. Okay, so the vascular endothelium is a layer that's common throughout the entire circulatory system. So can anyone tell me what the histological cell structure is for endothelium? It's squamous, it's simple. So it's simple squamous endothelial cells. Did I say epithelium? It's endothelium. So the endothelium, what it actually does is provides a non-stick surface between the blood and the tissue underneath it. And it also produces a lot of factors. And these factors can vasodilate or constrict or change vascular permeability, which maybe you would have covered when you were doing inflammation. And also is able to release factors that help with remodeling the vessels, that help with inflammation and things like that. The important thing to remember is that if you have laminar flow, so smooth flow, the endothelium creates more vasodilation factors and anti-inflammatory factors to maintain that smooth flow. Whereas if you have heaps of turbulent flow, then that increases pro-inflammatory and pro-coagulating factors. So there's a greater risk of clots if you have turbulent flow. Yeah. This is exactly what I said. Cool. So your vasodilators, you've got 3 of them. The most important ones are the first 2. So nitric oxide is a diffusible factor. So it's a lipid-soluble gas. It's very, very potent. It has a half-life of about 6 seconds. And it can also prevent platelet adhesion and leukocyte adhesion. So it prevents cells and stuff from sticking to the endothelium. Prostacyclin, or prostaglandin I2, is another diffusible factor, and it's a metabolite of arachidonic acid that is converted by the COX-1 enzyme, and it prevents platelets from sticking together. EDHF is just another vasodilator. The only thing that I remember from it, and the only thing that is probably worth remembering, is that it only is revealed when you block the production of nitric oxide and PGI2. And it also just causes hyperpolarization. Then you've got these vasoconstrictors. So with the factors, just know which ones are vasodilators and which ones are vasoconstrictors. You won't get questions asking like which vasodilator has a half-life of 6 seconds. You won't get asked that. You will get asked questions that are kind of like the next question that I asked, that will only involve you knowing, like with the recognition, like this is a vasodilator, this is a vasoconstrictor. So an individual presents with angina. An angiogram shows, new, that's meant to be new, shows new coronary artery obstruction. What have they written? An individual presents with angina. An angiogram shows no coronary artery obstruction, but shows vasospasm, which is consistent with misproduction of endothelium factors. Which is the most likely? All right, who's got an answer? B, yeah. So if you have angina, what that means is that there's reduced oxygen perfusion to the heart. And you only get that if there's vasoconstriction of the coronary arteries. And these are the 2 vasoconstrictors. Everything else is just wrong. Yeah, so this is the end. If you have any questions, you can message me. There's some notes in the drive. You'll be fine. You can email me. Cool. Enjoy your evening. And I'll put up the slides.
Attending each and every one of these.